Good afternoon, Robert, and depending on where you are, good morning, good afternoon, and good evening, ladies and gentlemen. My name is David T. Kaiser. I'm a Senior Scientific Education Manager at Geistig Pharma AG in Switzerland, and I'm responsible for the webinar World Tour together with my colleague Adam Raskatov. Today we are having the second webinar of this year with Professor Robert Carvalho da Silva from Brazil. Our next webinar will be on the 8th of June with Istvan Orban. Istvan will talk on preventing distances in major bone augmentation, so you can already put a date in your agenda. I repeat, Tuesday the 8th of June for the webinar with Istvan Orban. I'll now briefly introduce you to our speaker of tonight. Robert received his dental degree from Uberlandia Federal University in 1994. In 2002 he completed his master in periodontics and in 2004 his PhD both from the School of Dentistry at the Piracicaba Campinas University. He was the first recipient of the first edition of the E. Bud Tarson Award granted by the AAP in 2005. He is also professor at the Implant Perio Institute, Research and Advanced Dental Training in Sao Paulo. He is author and co-author of several scientific publications and chapters in textbooks with emphasis on periodontal tissue management around teeth and implants. He is one of the authors of the book Reconstrução Tecidual Estética, which was published in 2009. It got published in Portuguese, Spanish and Italian. He is also the author of another book that got published in 2016, Perio-Implantodontia Estética. It was published in Portuguese, English and Spanish. So Robert, thank you very much for accepting to do this webinar for us today. I give the word to you now.
Thank you, David, for this very nice introduction and invitation. And as a matter of fact, it's much more than invitation. It's like a summon to me. So whenever Geistlich needs my help, I'll be more than happy to participate and whenever I can. All right. So the topic of my presentation today will be related to the fresh socket management, and much more than that, trying to provide a decision tree to help the clinician to better treatment plan their cases. So pretty much when you have the opportunity to take out a tooth from the interior zone where aesthetics is very important, always in a minimally traumatic way, now we have to decide what to do with this fresh socket, always starting from this very, very nice, maintenance of the soft tissues in terms of the buccal and also in the papillary region. And we know that there are several alternatives to deal with that. All of those alternatives are very solid and sound, and they are associated with their respective list of advantages and disadvantages. And of course, that I will position myself like in a philosophical way. And trying to do that, I'm going to start showing you this clinical case. So this is a patient that comes in the office with already lost the left upper central incisor, so number 21. And of course, we can appreciate that already has happened here some decrease in the volume of this region. And when we observe the CBCT, what happens here is that we actually see that number 11, so the right upper central incisor, is retained, but it's broken. And now we have the opportunity to compare the volume of the socket around the existing tooth as opposed to the volume of the ridge of the tooth that has already been lost. And it's clear that the volumes are completely different. So where we have the retained root, we have the preservation of the dimensions of that socket. But the moment we lose the tooth and we have the healing of that area, we have now a resorbed ridge. And of course, that when we put them together, it is clear that we have some decrease in the volume of that region. So if we don't do anything about the extraction of number 11, what is going to happen for sure is that during the course of the healing, we're going to have some resorption in that area. So what we have to do here is try to counteract this kind of natural resorption that is going to take place. So the dynamics of the socket healing is quite important. And we know today what is going to happen. So from animal studies like this from Maurício Araújo and Lindy in 2003 and 2005, we have learned that when we took a tooth out, a very marked sequence of events will take place, and that will start with the formation of the clot that will be slowly replaced by the granulation tissue and the provisional matrix. Then we're going to have the modeling of the bone, which is the formation of the woven bone or immature bone. And after that, we're going to have the replacement of this woven immature bone by mature bone, which is the trabecular bone. And that process is called remodeling. And during this 8-week period of time in the dogs, we're going to have the completely fill of the socket volume with new bone, but you can observe that the lines that connect the lingual bone and the buccal bone are different now. And what happened here is that we have had a marked reduction in the volume and the height of the bone, especially in the buccal area, cervical area. And this is what is going to happen. So the socket is going to fill, but in association with some loss in the vertical, in the cervical buccal region. So what happens if we try to place an implant here in the fresh socket, trying to maybe counteract this situation? This has been done already by the same authors, and they have shown that the immediate implant placement would fail to prevent this buccal bone to resorb. And when we observe this line that pretty much shows the dynamics of the pattern of the resorption, we can see that the line coming from the lingual part, which is thick, towards the buccal, this line will divide the buccal bone in two areas. In the bottom area, we can see that we observe the medullary bone in between the two corticals. And the upper part, we only see a thin cortical layer of bone without the medullary space. This internal part, this cortical, is called bundle bone that belongs to the tooth. And the problem is that in the cervical region of the buccal bone, it's almost all compromised by this bundle bone, which again belongs to the tooth. And we know that the thickness of the bundle bone is very thin. And in this region is almost all compromised by the bundle bone. So the thickness of the buccal bone plays a very important role in the dynamics of the socket healing. Now the question mark is, how thick or how thin is the buccal bone in the humans, which are our patients? And many publications have already addressed that. One of those from my very good and dear friend, Dr. Alessandro Januario, who have seen that the average of the bone in the buccal region of our patients is actually 0.6 millimeters. So about 85% of those patients have the bone thinner than 1 millimeter. And about half of those patients is thinner than 0.4, 0.5 millimeters. And again, remember that the thickness of the bundle bone is about 0.4 millimeters. So the cervical region of the buccal bone is extremely thin and shall resorb. Another very important publication in humans is from this group, so Dr. Boozer and Chapuis, who have took two teeth out from the anterior zone, so upper anterior zone, and they have taken tomographic images right after the extraction, and they have repeated those CBCTs 8 weeks later. And they have observed that when the buccal bone was thicker than 1 millimeter, what happened is that almost no bone was lost in the superimposition of those CBCTs, as opposed to when they have a buccal bone that was thinner than 1 millimeter, it was almost all resorbed when they did the superimposition of those CBCTs. So that sheds light to the importance of the thickness of the buccal bone to the dynamics of the healing of the socket. But not only that, in this publication, it's clear for us that in this 8-week period of time, differently from what happened in the animals, in this moment here, 8 weeks later, we almost have no bone formed inside the boundaries of the socket, differently from what happened in the animals that we have already had here, a lot of bone forming in this area. So the dynamics of the bone formation inside the socket in humans is different, but we have this important information here that the thickness of the buccal bone will interfere with the maintenance or not with the dimension of the socket during this time. So when the bone was thick, we have like a minimal bone resorption in the central buccal area, as opposed to a very dramatic change or resorption in this buccal area due to the fact that the bone is thin. Another situation that has been shown here in this publication, that when the buccal bone is thin, it's going to be resorbed, and in association to that, we're going to have an important increase in the thickness of the soft tissues in the frontal area of our sockets. And because of that, it can be claimed that we might not need to use the connective tissue graft to further increase the thickness of the soft tissues because of this natural increase that takes place, especially when the buccal bone is thin. And we're going to talk about that later on. But here again, the importance of the buccal bone. And there's another publication which was very important as well, because it shows histologically what happens to the ridge in terms of bone formations in our patients. So the authors here, they have treated different patients in which a tooth was extracted from the anterior upper region again. And after different moments of time, they took core biopsies from the internal part of the socket. So in very early stages, intermediate stages, and the late stages where the bone was kind of completely healed already. And they observed that there is a great variability in terms of the healing time and the bone formation that takes place in the humans, which is completely different from what happened in the animals. So it seems that it's predictable that the bone is going to be formed, but it's kind of unpredictable in terms of the timing that we have in terms of bone formation. So the modeling, which is the formation of the woven bone, kind of happens in a very fast way, but the remodeling, which is the replacement of that woven bone by the trabecular bone, is much more slower and unpredictable in terms of the timing that is going to happen. And they also shed light to the fact that this process can be influenced by several factors, such as how the tooth was taken out, like in a flapless or a flapless approach, a minimal invasive versus traumatic way. The reason why the tooth has been extracted, because that entails already if the buccal bone was present or not at the moment of extraction. So the morphology of the socket in terms of the number of roots, the dimensions, the buccal lingual, the mesial distal, dimension of the socket, if the bone was intact or not, as I mentioned before, and what kind of prosthesis the patient used, if the patient is smoker or not. I mean, several aspects can interfere with that dynamics, and we have to anticipate and understand that. So if when we take a tooth out and we understand now that the buccal bone will be resorbed and we're going to have like a different healing of that socket depending on how the clinical situation here, we have to understand that this resorption is going to take place, and that must be considered during the timing of extraction. And if we don't consider that, what may happen is a lot of aesthetic nightmares, such as those. We can lose volume of the tissues that can compromise the aesthetics. We can have recession, we can lose the volume, we can have exposure of the titanium, and that can also lead to biological complications. So it's very important and key that we keep that in mind, trying to counteract this natural resorption that is going to take place, trying to do something to prevent that to happen to a certain degree at least. So after I mentioned that already, that I stated that, now is the moment to define what I'm going to do. And again, I have told you that there are different alternatives, but for us in implant perio, we should stick to the left side of our screen here. So I prefer much better to do immediate implant placement when I think it's possible to do the immediate implant placement, or if I don't think it's good enough, the quality or the anatomical aspects of that area, I'm going to try to improve the anatomy of that region and do the so-called socket preservation, socket reconstruction, as opposed to the other alternatives that the more I wait, the more I'm going to lose bone. And the more I lose that bone, the more traumatic and difficult in technical and biological aspects is going to be to reconstitute the volume of the bone that has been lost. It's going to be more traumatic for the patient as well. So I prefer much better to do the so-called internal socket compensation, as opposed to do the external socket compensation. So for me, there's no doubt what to do. It's much better to keep what is there as opposed to reconstruct what has already been lost. So this is why for us at the Implant Perio Group, there are only two alternatives to deal with the fresh socket, especially in the anterior zone. I'm going to do immediate implant placement or the socket grafting to preserve and even further increase the volume dimensions of that socket. And that has been already discussed in our sequence of books. And by the way, this is a QR code that you can find our book to see and to get it if you want. But there are other publications of our group as well, trying to show this kind of decision tree that has to be developed here now to define what is best, immediate implant placement or socket preservation. And of course, that this decision tree will be highlighted here right now. And basically, we have to understand 4 aspects to define the course of the treatment, immediate implant placement or the socket preservation. And those are the residual bone. When I say residual bone, I mean the apical and palatal part of the socket, the position of the gingival margin of the tooth to be extracted, the presence or not of the buccal bone, and the tissue phenotype. The most important 2 of those to define the course of the treatment, immediate implant placement or socket preservation, is actually the first 2, the residual bone and the position of the gingival margin. So actually, this is very easy to understand. So if I have the palatal and apical bone sufficient to place my implant in the proper three-dimensional position, and I have the gingival margin of the tooth to be extracted, to be positioned in a little bit coronal aspect as opposed to the adjacent tooth or my reference of the future margin of the restoration. It can be leveled to the adjacent tooth or the position margin, the future margin that I desire, or if it's like a little bit apical, no more than 3 millimeters. So if the buccal, the palatal and apical bone is present, and I have a situation of coronal positioning, level position, or no more than 3 millimeters apical to my desired outcome, then philosophically, we think it's safe to go for the immediate implant placement. On the other hand, if I don't have the apical and palatal bone to place my implant because it's so thin, and or I have a very deep gingival recession, in those cases, I'm going to move for the socket preservation. So it's very important here that to understand that the path of the treatment is determined by this interaction of the residual bone and the gingival margin position. The other two are, of course, very important, but they will not change, in our perspective, the course of the treatment, but they can change the way we're going to reconstruct the ridge. So in terms of the buccal bone, after we take a tooth out, we might have like an intact socket, which is always the best alternative for us, but we can have different kinds of defects. We can have those apical fenestrations, or we can have the cervical dehiscencies. And the dehiscencies can be divided or subclassified in terms of its depth and width. So it can be deep or shallow. It can be wide or narrow. And I'm pretty sure that you have already seen many times this situation, because as a matter of fact, think about your last 10 cases in the anterior zone. Try to remember those 10 cases. How many of those cases had the buccal bone intact? In our hands, at least, and in many clinicians that we speak with all around the globe, most of our cases related to this anterior zone do not have the buccal bone already because of the reason why the tooth is being extracted. We know today that depending on the reason the tooth is being extracted is already related to some degree of bone loss in the buccal area. Because if you have perio fractures, caries, many of those situations are already related to the absence of the buccal bone, at least in some aspects. Of course, that sometimes the buccal is present, but most of situations, the buccal bone is already compromised. And even if it's there, it's more likely to be very thin. So it's going to resorb very quickly anyway, as we discussed that. And I'm pretty sure that you have already heard this important phrase that no buccal bone, no implant. And of course, we acknowledge the fact that the absence of the bone is important and we have to deal with that. But we do not agree with this kind of sentence. Philosophically, we do not agree that if the buccal bone is not there, I should not do the implant. This is not how we think about it. So if we take in consideration that the implant should always be positioned in the palatal direction, leaving the room for the grafting that is going to take place regardless of the implant placement. Okay, so I can do the socket grafting here, but we must always have the space to fill this area with some biomaterial or some kind of situation. And we know, regardless of the implant placement, that by using specific strategies, it is possible to recreate this buccal bone that has been lost. And we can do that in different ways. we can use our biomaterials, we can use our membranes, and if we do the proper situation, it is clear for us from tomographic, histological, and clinical point of view, it's possible to recreate that pre-existing bone. So what is the strategy here? So I'm going to always use a good biomaterial inside the socket or buccally to the implant, or in the gap between the implant and the external area of the socket. So you can use different materials, but our choice is Bios collagen because it's very easy to use. It's kind of solid, but moldable, which can be very well positioned inside the socket or in the gap. And it will not resorb through time. And it will help the incorporation of new bone around the particles because it's very well osteoconductive. Okay, so this is what we do in all cases. But when we have the absence of the bone, but especially when the buccal wall deficiency is wide and deep, so I mean I almost don't have the buccal bone. So this kind of defect is very unpredictable. So it's very important that we help the healing of that area because of that unpredictability of this area. We call that a critical defect. And in the critical defect, which is wide and deep, we're gonna always help the healing using a collagen membrane. And the BioGuide shape is perfect to be used to kind of create a protection of the boundaries of the pre-existing bone from the soft tissues to get into. So this is much more like a guided bone regeneration procedure. So we can do that in the immediate implant placement or the socket preservation. So the biomaterials are the same. So in all cases, we're going to use the Bios collagen to fill the gap or the socket. But because in those situations, when we have a wide and deep fenestrations, we're going to use our membrane here, the BioGuide shape, in the outer aspect of the boundaries of the bone, so below the flap, but external to the boundaries of the bone, in such a way that we can protect that internal part from the action of the soft tissues, and that is pretty much what entails the guided bone regeneration. And of course, the last part of this scenario here is how the soft tissues interfere with our clinical reconstruction. So regardless if it's going to be immediate implant placement or socket preservation, when we have thin tissues, we have to anticipate some kind of recession that might take place. So please observe with me these two CBCTs from two different cases that both of them are related to teeth that are going to be lost, and there is absolutely no buccal bone here. So this is the very similar tomographic situations, but please observe that the clinical scenario is much, much, much different, because in the upper case, although no buccal bone is present, we have a very deep gingival recession, as opposed to the lower case where the buccal bone is not present at all, but you can see that the soft tissue is even a little bit coronal to the adjacent tooth. And that happens because of the thickness of the soft tissue in the lower case, which is thick. So whenever we have a thinner situation, whenever we have a thinner phenotype, we're going to always add a connective tissue graft to further increase the volume of that region in such a way that we can improve the quality of the tissues and prevent some kind of recession that can take place later on. And this is pretty much what we do in every single case in terms of the reconstruction, regardless if it's a mid-implant placement or socket preservation. The biomaterials are the same. So when we have a very dramatic loss on the buccal area, we're going to use the membrane the BioGuide shape is going to be used, and the biomaterial in the implant placement or the socket preservation is going to be BIOS collagen. And very frequently, we're going to further increase the dimensions of the soft tissues here using the connective tissue graft. So we know that this philosophical approach can be quite different from other groups, especially when it comes to the presence or not of the buccal bone. And we know that every single scenario have its advantages, disadvantages, and there are literature supporting everything. So I like always to say that there is evidence for everything, but there is no consensus for any of those situations. So you must have your own experience to do the cases according to the literature, of course, but trying to see what happens in your cases and trying to figure out the best way to go with your own patients. So now let's move to the clinical part of my presentation. After I have, I hope, clarified a little bit of how we think about these strategies. So I like to start with this very, very nice case from my friend of mine, Augusto, who is a dentist, who unfortunately had a trauma some years ago, and he has developed these darkened teeth. But as you can see, regardless of the color of his teeth, he has a beautiful stippling of the soft tissues, a very thick and wide band of keratinized tissue. And in the CBCT, we can observe that the buccal bone is present and it's very thick and it's there. But unfortunately, in the X-ray, we can also see that there is a root resorption here on the mesial aspect of tooth number 11. So obviously, we have to take that tooth out. So we took the tooth out, we placed the implant, immediate implant placement, because the apical and palatal bone was present, okay? And the soft tissue of this patient was really good. As a matter of fact, he has an excess in the vertical dimensions of the soft tissues related to this kind of gummy smile. So we also did here like a small crown lengthening procedure. And of course, we did our temporization and we did our grafting here. In this case, BIOS in the buccal area of the gap. And what happened is that now we have a completely satisfied patient. So nobody in this virtual room can ever tell that Augusto has an implant supported restoration. This is impossible to say. Even after 4 years, the quality of the soft tissues is perfect. Now the color of the teeth are corrected because of the veneers that were also delivered here for him. But most impressively is that the leveling of the gingival margins of the implant supported restoration and his adjacent tooth is perfect. And the volume of the gingiva is also perfect. So this is pretty much what entails the success of this concept. And in order to be successful, we have to follow this triad of the excellence of the perio-implantology. And that is to place the implant in the proper three-dimensional position. And we have to do the aesthetic tissue reconstruction, which means the bone and soft tissues in most of the cases. Okay, so we have to deal with the reconstruction of that area, regardless if it's immediate implant placement or socket preservation. And of course, that we have to do the prosthetic management in a very, very precise way, because we know that many of the problems that are related today, they should not be related to the timing of the implant placement. We have a lot of problems of aesthetics in implants that were delivered in later stages, and that was associated with the wrong concept of the prosthetic of the prosthesis, like the excess in the convexities on the cervical region can lead to gingival recessions. So again, we do not accept this concept that immediate implant placement leads to static complication. It is not the timing of implant placement that produces complications, but if you don't fulfill this triad of the excellence of the peri-implantology. So again, always remember that implant positioning in the three-dimensional way, the aesthetic tissue reconstruction, and a proper prosthetic management. Now let's see complete cases to show some situations. So this is a young patient with extremely high smile line. And we can see already that something is going on her tooth number 11. So the right upper central incisor that is different from the other tooth. The soft tissue is a little bit reddish, showing that there is some inflammation there. And here we cannot make mistakes because this is much more an outdoor, a walking outdoor of our work. So we have to be invisible, such as I just showed you in the Augusto case. I want that nobody can tell that this patient has something going on here. And what we see here is actually a patient that has a fracture in this central incisor, so it has to be removed. But we have the socket which is preserved. So the buccal bone here is very thin, as you can see here, but it is preserved. So we have here an intact socket. And the soft tissues here are preserved. So if I have the apical and palatal bone preserved and the soft tissues are there, why should I take this tooth out, wait 8 weeks in order to lose that volume of bone, lose the volume of the soft tissues, and then place our implant in a later position? So philosophically, this is not what we like to do. So I'm going to take out the tooth in a very minimally invasive way, as I just described it before. And now, because I have the palatal bone and I have the buccal, the soft tissues in a very good position, I'm gonna for sure go for the immediate implant placement. So we have to choose now what implant you have you like to use. So it's open to you, but it's very important that this implant is very well threaded to find a good primary stability. Today, we must always use smaller diameter implants to create more room buccally to that implant so that we can graft in that area, and it must be platform switched in such a way that it also helps to preserve the interproximal bone. So the implant was positioned in a three-dimensional way, and it has a very, very nice primary stability. So before we go ahead to the reconstruction phase, we give room for the prosthodontist here to deliver the provisional restoration. So here we can see that the prosthodontist has positioned the titanium post, the provisional titanium post, and on top of that, he's going to perform or reconstruct the provisional restoration, but not in any way. He has to be very, very precise, especially in the contours of the critical and subcritical aspects of this provisional restoration, which are below the gingival margin, in a way not to put any pressure on the soft tissue that might lead to recession, but yet providing support for the papilla and the gingival margin. So it's very, very important that we take that into consideration, not to jeopardize our static clinical outcomes. So in order to place this immediate temporization, it's very important that we find a very good primary stability, at least 35 newtons, okay? The implant has to be very well positioned, as I mentioned, and the occlusion of the patient must also fulfill these possibilities. And if we do that, if we are able to deliver this immediate temporization, of course, that the patient is going to have a good aesthetics, comfort. It's going to be easier for him to clean this area, but most importantly, it will provide the right and proper support for the gingival margin and the papilla. And if by any chance we don't have a good primary stability or the occlusion of the patient do not allow, even though we can improve this kind of support of the soft tissues by performing what we call the custom healing abutment, which is essentially doing the provisional restoration, but cutting it in the level of the tissue of the gingival margin in a way that will support the soft tissues, but would not put the implant in danger of getting lost because of some kind of mobility of that implant or related to a low primary stability. Okay, and after the provisional restoration is being performed and now he's polishing it, it's now the moment to do our reconstruction. So inside the gap, as I mentioned, we always going to use the Bios collagen because of its features that I already mentioned before. And in this case, we don't have to worry about the membrane because the buccal bone is completely intact. So we just have to pack this biomaterial inside the socket, the gap, always protecting the rim of the implant with like a healing cap in such a way that the biomaterial do not go inside the internal chamber of the implant. So after we do that, we now deliver our provisional restoration, of course, but I like to show you the benefits of filling the gap. So what happened, there's a lot of literature showing that when you use this kind of material or any other material of your choice, but preferably biomaterial with this kind of characteristics, is going to compensate the remodeling that's going to take place. I mean, the buccal bone will be resorbed exactly the way we mentioned before, because this part of the bone is related to the tooth that is going to be out. But because this material is hard and is going to stay there, when the resorption gets to the level of the biomaterial, it not go further away in such a way that we're going to preserve most of the volume of that area. And we say that it's a compensation of the remodeling. And if you don't do anything about that, so if you place the implant but not fill the gap, what's going to happen in most of the cases, because remember that most of the cases we have a thin layer of bone, and 85% of our patients will have a very thin layer of bone. This is going to resorb and going to collapse. And by collapsing, we can end up having no buccal bone anterior to our implant, and that may lead to aesthetic and biological complications. So please always think about that. And as I mentioned to you, especially in the anterior cases, especially when you have thin tissue biotype, which is not the case here, but this is like, remember, an outdoor that is walking around. So I don't want to mess around with that. So I want to improve the thickness of that area, and for that we do our subepithelial connective tissue graft. So we create a pouch in the buccal area, creating the room for the introduction of our connective tissue graft. But please observe that here we have not touched the papilla. So it's like a buccal pouch without touching the papilla, all right? And then we slide this connective tissue underneath, and we hold that, in a horizontal way, in the buccal area below the height of the interproximal papillas, and holding that with 2 interrupted sutures. Why we do that? We do that because we want to increase the soft tissue thickness, and by doing that, we're going to decrease the likelihood of gingival recession. We're going to reduce the likelihood of the deficits in the contour and providing the possibility of having gingival transparencies, which is bad for aesthetics. But not only that, we also improve the emergent profile of the prosthetic restoration, favoring what we say the tissue conditioning of this region. So this is the occlusal view of our patient here. with the implant well positioned, the socket being filled with bios collagen, and the connective tissue graft exactly underneath. And please observe that the position of the connective tissue is very close to the gingival margin, and it's also below the areas of the papilla, which is very, very important to be successful. Our provisional restoration now was being positioned here, so very nice. And this is the patient 6 months later. Please observe that now I have a gingiva or gingival margin that is a little bit more coronal to the position of the adjacent tooth. Not only we have improved the thickness of the area, but also we gained a little bit of tissue in the vertical direction in such a way that now it's easier for the prosthodontist to start to move these tissues and shape these tissues in the best way he desires to improve the best aesthetics for our patient. So 6 months later is the timing that we generally think, between 4 and 6 months in most of the cases, when the first time the provisional restoration will be removed. And here you can see this beautiful volume of soft tissues that we have here right now. And many oftentimes we can see some particles of the biomaterial within this area that we're going to remove with a periodontal probe, a very, very minimally invasive way, very simple way, and just to remove it there, not to cause any kind of inflammation. But now you can appreciate the volume of this area. So I don't think this tissue will ever recede because the thickness of the soft tissues, it's very, very impressive. So here you can see that. So this particle here have to be removed, but in a very easy way. You can see how healthy these tissues are. And of course, this moment we're going to take our impression and start the prosthetic maneuvers, as I mentioned to you. When please observe that the abutment that is here now is supporting the tissues, but yet creating the space for the adaptation of the crown that is going to be placed in here. And this is the comparison of how we started. And this is like 6 months after the case was finished. We can see that now the leveling of the soft tissues are corrected. We have a beautiful stippling of the soft tissues here and the volume. And please observe this thickness of the buccal bone here in this area. Of course, this is only 6 months, so we have to follow this patient. But here you can appreciate that the smile of the patient do not show any kind of disturbance in terms of aesthetics. So it's like very pleasable, and it's invisible to the eyes of whoever is talking to this lady. This is 2 years after we finished the case. You can appreciate that, that the tissues here are very well preserved, and the volume of the soft tissues here are incredibly stable. So this is the comparison before and 2 years later. This is 4 years later, and you can see that the tissues are even better, because with time there is like a late maturation of the connective tissue, and we always see at the long run better clinical outcomes when we add the connective tissue. And here 4 years. So this is how we started. This is 4 years, occlusal view, and this is a beautiful demonstration that the volume of the tissues here are really, really stable. And this is 7 years mark, where you can see that everything stayed in its position, quite stable, no recession, no inflammation, and a very nice and beautiful resolution. And again, this occlusal view showing how beautiful is the possibility to reconstruct this area in the best way possible. And here how we started and how we were able to maintain everything stable during this 7-year time. So why do you use the connective tissue? Like an external compensation. Remember that inside the socket, we're going to use bios collagen. But this thin layer of the bone, we always resorb in most of our patients, because most of our patients have a very thin layer of buccal bone. So some loss in the volume is expected. And to counteract that, this is why we do the external compensation using the connective tissue graft. And today, even in the cases where the tissue biotype is thick, we increase the volume of that area to prevent this kind of later shrinkage of this area. And we have a lot of literature showing the benefits of placing the connective tissue graft. And even today, an extra concept that is gaining attention again. We know that for a long time, but we know that when the soft tissues are thick, there is a better chance to preserving the bone around our implant. So we have minor or no bone loss because of this volume of soft tissue. We're going to improve this tissue, as I mentioned, and that will lead to no or much less recession, as opposed to cases that we do not use the connective tissue. So in our perspective, the connective tissue graft is a very important part of our philosophical approach. And what happens, as I mentioned, if I place the biomaterial and not place the graft? So this is only a parenthesis here in my presentation. I'm going to show this very quickly case here in only one slide, where we did exactly as I mentioned. We took this tooth out. Okay, so this tooth is broken. We took it out, and we placed it here, our biomaterial, which is the bioscollagen. So the immediate placement was performed. We did the immediate temporization, but we did not use the connective tissue graft in this area. And when we look to the CBCT after some time, we have this beautiful reconstruction of the buccal bone to the head of our implant. So the bone is here, and the soft tissues is leveled to the adjacent tooth. But please observe always the occlusal view of those cases. And you can see here that because the buccal bone is present, I'm not going to have recession, but that will not prevent the loss of the volume in this cervical region. So today, in our humble opinion, the placement of the connective tissue graft in the outer layer of the bone, it's very important for this external compensation to prevent this aesthetical complication that can take place. So let's move to a more dramatic case, also related to a fracture on number 11. But in this case, we have gingival recession, not only on number 11, but also on number 21. So the provisional, the crown that was broken was repositioned there for aesthetic reasons for some time. And then we were able to convince the patient that we have to take the tooth out. So please observe that it's already some inflammation here because of the fracture that was going on. And we can see here that there is a recession here. And when we probe this area, we have a very deep probing depth, which entails that we have here buccal deficiency. And we can see in the x-ray that there's no buccal bone here in this area, but the palatal bone is present. And the recession is no more than 3 millimeters. So we take the tooth out at this moment, taking into consideration the 4 parameters that I have described to you before. So there is a recession, but the palatal bone is there. There's no buccal bone, but the palatal and apical bone is there. So we're going to probably do our immediate implant placement. So we take the tooth out. You can see the root fracture there. That is the cause of the loss of the buccal bone. And the more we wait, the more we're going to lose that bone. Now we take everything from inside. So the granulation tissue has to be removed in a very effective way. we know already that we have a deep fenestration, but also it's wide. So I have a deep and wide fenestration, meaning that in this case, our decision tree will determine that the reconstruction has to also be associated with a membrane in this area to anticipate the guided bone regeneration concept. So the implant was positioned here using a guided surgery. So the implant very well positioned. Now is the moment to create a pouch for the recreation of the tissues that are missing. And in those cases that we have to place the membrane, we always start the reconstruction from the outside to the inside. So because we have a recession here, we have already created the pouch, not only on the central, but also on the other central incisor, so both teeth. And now we place our connective tissue. So in those cases, we always start with the connective tissue. All right, so the connective tissue will be positioned below the gingival margin and stretched in a way to be buccally positioned in those two teeth, the implant, and also on the adjacent tooth. Okay, and now is the moment to place our membrane, below the connective tissue. So we have the flap, we have the connective tissue, we have the membrane, and we have the gap, and we have the implant. So it's always important to place the connective tissue first, because if you put the membrane first, and then you're gonna add the connective tissue, because the softness of the membrane, you're gonna probably remove it from this best position. So first the connective tissue, now the membrane, and now the layer of the bios collagen inside the gap. And this is what we see from the occlusal view. So the flap, the connective tissue, the membrane, and the bone, which is inside. And now, of course, we place our provisional restoration. We always add this kind of extra sutures to bring everything to the coronal direction. We see this beautiful volume of the soft tissues, but we also see that in this case, we may have had to do a little bit of extra condensation in this area, okay? But this is the reality of the cases. So maybe I could have done here a better job in terms of the compression of the biomaterial, but I have used the connective tissue grafts. So another parenthesis here. So this, I'm not showing you one or two cases, okay? We have been doing that for a decade, more than 10 years doing this kind of concept. And we have already collected many, many cases. We are now preparing a publication trying to show, again, this concept, but now with a more scientific approach. And in several cases that we have collected here, 20 patients to start this publication, this new publication, we have taken teeth from the anterior zone, from the canine to canine. All of those cases related to a damaged socket, so no cases related to preserved buccal wall, so all of them related to the deficiencies in the buccal bone. And in all those cases, we did the immediate implant placement and the aesthetic tissue reconstruction. In all cases, we used the bios collagen. So whenever we thought that the connective tissue was important, and that was most of the cases, we also did the connective tissue, and we did the BioGuide in 10 of those cases where the deep and wide defects were present. In the other kind of defects, we did not use any kind of membrane, because those defects that are not wide and deep are more favorable defects, are not critical defects, and we have been seeing that for a long time that we don't need the membranes for those cases. And of course, we did the immediate temporization or the custom healing abutment. And we did the CBCTs prior to the surgery, and after at least 1 year, okay? So in this case, in the post-op too, in many cases, we did the immediate post-op CBCT, and all cases at least 1 year of follow-up. And what we saw in those cases where the buccal bone is not present is that in every single case, we see this excess in the volume of the biomaterial buccally to the implant, but through time there is a kind of compression and it comes to its normal position. And from zero bone, in the average, we have 2.87 millimeters, and all cases more than 1 millimeter thickness of bone in those clinical situations. And this is our patient again, 6 months after the healing, where now we can see the correction of the gingival recessions, but now not only that, a very stable soft tissues around our implant supported restoration. This occlusal view, again, it's very important to highlight, these soft tissues which are protruded from the cervical region of the restoration. So I don't want to see a butt joint situation, the soft tissue margin and the cervical restoration. I'd always like to play and say that the gingiva has to come in the room first. So it has to be protruded in terms of the cervical region of my restoration. And 6 months time, this is the moment to take out the provisional restoration and do our impression taking. And again, you can see the beautiful volume of the soft tissue here, and the bone is going to be preserved, of course, and everything is going to be fine. And this is like the resume of this concept. So the static tissue reconstruction in association to an implant that is well positioned and the prosthetic management. And this is how the patient was finished after the crown was delivered. We have a very nice situation here, but look, the occlusal aspect, which entails, again, the gingiva thicker and coming in the room first, as I mentioned to you. And this is how it finished. And please observe this. So here I had no buccal bone, and then we packed the biomaterial, but maybe in not the best way possible. So that was a compromise. And after some time, we had this thinning of the buccal bone, maybe related to my mistake here in terms of the condensation of the biomaterial, but always more than 1 millimeter thick. And regardless of this loss of the volume of the bone, because I made a mistake here, okay, see the volume of the soft tissues that did not change. So again, 3 years follow-up, everything holding up perfectly. No loss in the proximal, the soft tissues are leveled, and we have this beautiful maintenance of that area. So I'm moving towards the end of my presentation to last quick cases. And this is a very, very nice case that we have done many years ago. So this is a deep recession on number 23 that came to our course that we're giving in one of our extension programs that we give. And the case was treated like a root coverage case. So we did the coronal advancement of the flap associated with a connective tissue. And this was the outcome after 3 months. Then we repeated a second connective tissue with an L-shaped one single incision on the distal aspect. And this is how the patient healed, like almost all covered, like 100% wood coverage in this very big gingival recession. And this is the patient 4 years later during the maintenance. Then the patient didn't show up for some time. And this is the patient 7 years later. So three extra years after the 4 years mark. And when the patient came, we already saw this reddish zone here with a small gingival recession. And there was a big proben depth here. So a pocket has been developed here in this area. And the CBCT shows that there is an external resorption here in the apical region. And of course, that we knew already that there's absolutely no bone here. But please observe that the palatal and apical bone is preserved, and we have a small gingival recession here in this area. So Shallow gingival recession, no buccal bone, but a good anatomy of the palatal and apical region. So according to our philosophy here, we're going to take the tooth out, we're going to place the immediate implant placement, and we do the aesthetic tissue reconstruction. So the connective tissue, again, because of the gingival recession, first, second, the membrane, third, bios collagen, and then, of course, we placed our provisional restoration because the implant stability was very good. And this is 2.5 years later, seeing that the completely resolution of the buccal bone that was completely absent. And we have here a very, very nice situation. So, of course, that we have indicated the orthodontics for this patient, but he didn't want that. So we just moved with the way he was at that moment. And please observe the volume of the soft tissues here that we have because of the connective tissue and the support of the bone. So this is how we started. And 10 years later, after we first saw the patient, in this moment, like 12 years later, but in the picture, 10 years of follow-up. So a very, very nice situation. And the last case I'm going to show you is this very difficult clinical situation where the patient, which has a high smile line, a fractured central incisor, but with a very deep gingival recession. So in these cases, we have to not do everything immediately because we have a very deep gingival recession. So we try to do a staged approach in this case. So the very first thing we did here was to kind of do some grinding on the buccal aspect of that tooth. We tried to bond the broken tooth there just to give support and maybe create some space for a natural soft tissue ingrowth in that area. After that, we did a connective tissue graft to further improve the position of the soft tissues. And this is how it healed. So we were able to completely cover that recession using the connective tissue graft. And after some months, now is the moment to do a minimally invasive procedure. So a very tiny incision where gave room for our instrument to take out the root, to clean the area, and we did the implant. No buccal bone, but of course, the membrane and the biomaterial. And in this case, at this moment, we did not do the connective tissue graft. So what happens is that we have lost some volume in this area. So what we have to do now, to a secondary procedure again, to place the connective tissue. So not only in the buccal, but also in the occlusal aspect. So like a vertical augmentation of the soft tissues, not only in the buccal. And then after it has healed, we started to do like a reopening of that case, but not with the blade, but with the provisional restoration. So the prosthodontist here started to add a little bit of acrylic in the cervical region of the provisional restoration. And through time, he was able to get to the head of the implant and finally connect the provisional restoration to the implant head. And after some time, you can observe that the shape of the contour of the soft tissues is completely perfect. And this is the emergent profile that was recreated out of nothing. There was absolutely no buccal bone and no tissue, and we are able to do it in a staged approach to get to this point. And now, of course, that the prosthesis was delivered, and now we can appreciate that the leveling of the soft tissues and the complete reconstruction of the tissues, and how the patient started and how the patient was finished in a very, very nice way. And this is 1 year follow-up, no buccal bone, but now we have the recreation of at least 1 millimeter of buccal tissue, buccal bone, But because of the connective tissue graft, in this case, 2 connective tissue grafts, sometimes we have to do more, as I mentioned to you. Please observe that the gingiva comes first in the room. So it's protruded in terms of the cervical restoration. And now we have here a very, very happy patient. And this is the 3-year mark that shows completely stability in this situation. Of course, that we are following this patient. And if I'm invited again next year, I'm going to show the 4-year mark, and the other year, the 5-year mark, and eventually the 10 years mark as well, showing the stability of this approach. But for sure, beautiful sequences of images showing how the aesthetics was affected by this situation. So before and after in this lateral view, completely amazing how this kind of philosophy can improve the quality of life of our patients. So as a conclusion here, we're going to do immediate implant placement or socket preservation, depending on the 4 parameters that I have shown to you. The most 2 important are the apical and palatal bone and the gingival margin position to determine the path of the treatment, immediate implant placement or socket preservation, always using a flapless approach. And in our philosophy, the buccal bone do not interfere with our decision, but will interfere with the way you're going to reconstruct the area. So many times we need to do this envelope-like pouch in the buccal to place our membrane when we have a deep and wide fenestration, and of course, to add, in most of the cases, subepithelial connective tissue graft in such a way to improve the area. So again, a final message: success in implant supported restorations is pretty much related to the 3-dimensional implant positioning, the aesthetic tissue reconstruction, and a very nice and precise prosthetic management. All of that can be seen in our work, and you can see a little bit of our work and decision trees at our book. Again, here you can appreciate the QR code to get to that point. And with that, I thank you very much for your kind attention, and I'm looking forward seeing you in person in the near future. Thank you very much. I'm all for your questions right now.